I'm your host again today, Dr. Suzette Sutherland. I'm excited to have Dr. Kelly Casperson as our guest for this special episode discussing a variety of issues pertaining to women's sexual health. Good morning, Dr. Casperson.
Good morning. Thanks for having me.
There are so many men's health clinics all over the country. You can't get online without seeing something about how it's going to make your erection bigger and all that. And, that's wonderful that men have resources, but there's really such limited stuff for women, and the focus is just not on the women at all. But how much of that is because of our limited knowledge? You said we do know quite a bit, but I think when we look at the science and what we have, where do you think we are with respect to the science, and where can we be moving forward to understand more about what causes some of the problems of women, and then ergo, how to fix that?
Yeah, urologists and physicians in general, we're in the same pool that everybody else is in. And what that pool is a really crappy sex education system, right? We got a disease and pregnancy prevention plan. We never learned to communicate. We never learned that there would be roadblocks and bumps and difficulties, right? So we are just as awkward. And most medical schools, and there's data on this, most medical schools do not provide good training in how to communicate to patients about sex. So it's awkward for everybody. And doctors really haven't done a good job of making up for the deficiencies that we got along with everybody else in terms of sex ed. So really talking about the bias of do we let women be sexual? Are they sexual beings? Do we think it's a problem when their sex life is different than it used to be? Do we judge them differently than we judge men? And really thinking, even the biopsychosocial, right? For once Viagra got invented, this was a blood flow problem. And we really ignored the relationships, the stress, the anxiety, the performance anxiety, the stress that can affect erections, right? We kind of really made it biologic. And I would argue in the female domain, and again, I'm oversimplifying, but we really make the female domain you're just stressed, you're just anxious. And it couldn't possibly be a blood flow problem, couldn't possibly be a side effect of your diabetes, couldn't possibly be a side effect of your antidepressants, right? We've taken the biologic out of women and made it all about their brain. And so really making sure we're thinking of both humans in the biopsychosocial realm.
What would you say in your practice that you see, or your knowledge of what the prevalence data is today? What is the prevalence of some type of female sexual complaints in women?
Oh, yeah. It depends upon age group and how you ask the question and blah, blah, blah. But about 40%, it's very similar to male. Erectile dysfunction, 40% by age 40, according to the Cleveland Clinic. Probably the same for female. So we're not unique. Where do we start? Women are special. No, we're not unique. We're humans, just like those humans. And we've got the same issues. And we need to address them just the same. But going back, a lot of people are female sexual dysfunction. Some people don't have sex lives, and they're perfectly fine with that. We're never here to say you should be having sex. You need to be having sex. So a big thing about defining female sexual dysfunction is, are you actually bothered by it, right? And the second part of that is going back to how bad our sex ed is. Most people don't know that women don't orgasm by putting something in their vagina. So we're having women in heterosexual relationships having penis and vagina sex, never having an orgasm, faking orgasms. We have a disaster of a sex education. They don't know that the clitoris is important. People don't know where the clitoris is. So you have a woman come into your office, you got to step back and be like, okay, how do you have sex? What is it, an orgasm? You got to ask the right questions, because education goes so far. That lubrication helps orgasms, and people are all judgy about lube, right? So we can get into the medications that are available, but I always say I never prescribe a medication on the first date unless it's vaginal estrogen, because they need the education. And that's why I say, go listen to my podcast, go read the book, start learning how to communicate, especially if we are talking a sexless marriage. It's been 6 months, it's been 2 years, it's been 8 years. And I would argue that the advent of Viagra was not great for relationships. It's a disruptor, and we have papers on that. Because when you provide one person out of 2 with better sex and you don't address their partner, whether it's genital urinary syndrome of menopause, pain with sex, low desire, you have created a rift. And I would say urologists are part of the problem, often more than they're part of the solution. When a guy comes to see me for Viagra, I always ask about a partner. Is there a partner involved? Is she seeing somebody? Are her needs being addressed? Have you communicated to her about your plan for bringing home the super penis? Right?
Right.
10 times out of 10, they have not talked to their partner about it. I think urologists are in the dark.
I can't tell you also how many times on every new patient I ask, are you sexually active? That's one of the categories, right? You go down the plethora of questions that you're asking that have to do with pelvic health. And I get so often, well, ... pause, I'm married. I'm like, oh, what does that mean, right? We all know in our own minds what we think that means in maybe, a woman in her 40s, 50s, 60s. It's alarming to me how many younger women, though, say that too, are in a relationship, have several young kids at home, and say something like that. So it's not just the postmenopausal 60, 70-year-olds that are saying that, right? And that's where I think that we really have an opportunity to make a difference, right? And to try and bring the joy of the sexual, encounter, the sexual endeavors back to the relationship for the woman, not just to be something that she's obligatorily doing her marriage duty, whatever, though.
Yeah, I mean, that's very, very important. It's very common. It is not researched enough. I've been begging people to research this because we have a lot of research on consent and these kind of desire in like college students because they're easy to research because they're at a university, right? But as far as like a heterosexual older person, 30, whatever, not in college, the obligatory sex, duty sex, pity sex, whatever you want to call it, a woman cannot say hell yeah to sex if she can't say no. And that is a big issue. Again, it's our sex ed, learning that no means no. And if you're having sex for somebody else, especially if you're having sex to control somebody else's behavior, he'll get cranky, he'll get pissed, he'll get mopey. I'm having sex to control somebody else's behavior. Sex isn't awesome for you. It is not about you. You can never get to a hell yes if you're performing an act for those other things. And again, there are not enough sex therapists in this nation. Like, we need way, way more. Women will come in and they'll say, I have low desire. And we say, great, we've got some FDA-approved medications for hypoactive sexual desire disorder, right? But if there is other reasons that they have low desire, because sex is not about them, their pleasure is not considered equal. Orgasms are not considered equal. Orgasm gap, many people, again, haven't heard of that, but the heterosexual relationship is the widest orgasm gap. Heterosexual male has an orgasm about 97, 98% of the time when he has penetrative intercourse with a female. She has an orgasm, and an orgasm, a marker of pleasure, right? We can argue if that's the proper marker of pleasure, but they're using that as a marker of pleasure. She has an orgasm about 60% of the time. That's in a committed relationship. Way worse with hookup sex, college campuses, 30% or less. So we are largely biased in who gets to have the pleasure in these scenarios. And if somebody's having less pleasure, you're going to desire it less. That's just dopamine.
I think this brings us into more of the orgasmic category. And let's just talk about that for a minute while we're on that topic. Is just really the very phallocentric idea of intercourse and what that's supposed to do for women that we see in older movies in Hollywood, right? Just that moment of penetration and she's having an orgasm, which is so false, versus the role of the clitoris, and then what kind of education we need to do for our partners, whatever gender our partners are, as to how that's really the orgasmic organ.
Talk about things you didn't learn about in medical school, right? And the reason, the clitoris is amazing. It's the one organ in any body whose sole job is pleasure. That's a freaking cool organ, right? And then you're like, what about the penis? Penis has 3 functions. For all the urologists listening, it has to pee, it has to get semen out, and it has pleasure. So clitoris has one function, pleasure. We don't get taught about it. And then our sex ed includes penis and vagina, don't get pregnant. So it really is the organ of pleasure. It is innervated like a penis. It looks like a penis. These are homologous structures. So if guys think their penis is a big deal, that's what a clitoris is.
That's awesome.
Most women who orgasm because of penetrative sex, one of 2 things are happening. Number 1, they're getting concomitant clitoral stimulation. Number 2, their clitoris anatomically, some clitorises are just closer to the vaginal opening, so it's getting attention that way.
So that's really a very good point, right? So again, even when people talk about the G-spot, right, and they talk about different positions with intercourse, and so we don't really know a lot about the anatomy of the G-spot. We know that there was a lot of hype in the 70s about that, but some subsequent data shows where some sensitive areas in the vagina are, but not as sensitive by any means as the clitoral area and with respect to orgasmic ability. So
yeah, the G-spot, the modern term is the G-zone. It's not a spot that makes people think it's small. It's not small. It is the periurethral, basically where you're making an incision for a sling. So it's anterior vaginal wall, about an inch in, underneath the urethral clitoral complex. When it's innervated, you are innervating clitoral nerves, basically. So think of it as one and the same. It's an internal way of hitting the clitoris.
But then when you say that too, if you, again, to make that point about the innervation of the clitoris versus the intervaginal wall into the urethra in this G zone, with surgery, we don't have women that have a sling surgery and they can't have an orgasm now, all these women. So again, it just speaks to the difference in the innovation and the intensity of the innovation of the clitoris and how much more important that is.
Yeah, I mean, I think any sling surgery should have a consent that this could affect sexual function. I think we do that over and over with men and prostates and penises.
Oh, absolutely.
We should do that. But the data suggests that you fix a woman's incontinence, her sex life gets better. So there's many data saying the sling actually is great for your sex life because now you're not self-conscious about leaking. Your body image is feeling a little bit better. It can be good. But there should be an informed consent of like, hey, it's pretty rare, but we're operating around the area.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Orgodzinski.
Show notes and social media by Jody Lenora.
Administrative support provided by Jamila Kennebrew.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.